sound rays, and as a result you get that sort of appearance. The other thing you can do is you can just move the shoulder around, and by moving the shoulder around then you can more clearly appreciate that there isn't a supraspinatus tendon there. So do watch out for that. It's a very common mistake when people start doing shoulder ultrasound, to misdiagnosed supraspinatus tendon tears. Now the other thing that people have trouble with when they first start looking at rotator cuff ultrasound is basically finding people with moderate to severe degrees of tendinosis. You must realize that areas of hypoechogenicity within the tendon are very common features of tendinosis, and with severe tendinosis it's very common to get many small intrasubstance tears. So this patient I would report as something like severe tendinosis with several small intrasubstance tears. Nothing you can do about that really. The main thing is just to recognize that when you've got tendon thickening like this as a result of tendinosis, you will see areas of hypoechogenicity within it. You will expect to see this pattern and just appreciate it like that, these do not represent tears. This is a normal feature of tendinosis. And then when you come to more severe degrees of tendinosis, then you will often see these hypoechoic lines within the tendon. Don't go around measuring these and count and reporting these as intrasubstance tears. These are, yes, they are tears, but they're not of any surgical relevance. So just report this as severe tendinosis with several small intrasubstance tears. And being able to recognize tendinosis and the range of tendinopathy is a very, very important feature of rotator cuff ultrasound. You can see hypoechoic areas like this very commonly, but you expect to find those areas of hypoechogenicity in people with tendinosis, and do not misdiagnose them as tendon tears. Now, in people with relatively normal tendons, this person's got mild tendinosis. Now, in these patients, if you see areas of hypoechogenicity, then yes, you can report small intrasubstance tears in these patients with relatively normal tendons. But as I mentioned, in the patients with moderate to severe tendinosis, I tend not to report these small intrasubstance tears. But in people with more normal tendons, you can see the intrasubstance tears much more clearly. When you look at people with severe tendinosis and you're looking for tendon tears, you've got to rely a lot more on the outline of the tendon. And here you can see this clear volume loss in this area. So when you see this volume loss, then this is an indicator of a tear in this area. So when people with moderate to severe tendinosis rely more on volume loss, localized volume loss, then rely more on localized volume loss rather than specific features. You often have to do this to diagnose tears. Sometimes tears in these patients may be quite difficult to detect. Don't worry about it. It will all come with experience as you get more and more experience with rotator cuff ultrasound. But it's just, these are the potential pitfalls you may encounter now. Anisoptrophy is a continual problem. It's related to the angulation of your probe and the ultrasound fibers. So often when you're scanning patients and you're starting off scanning, just go back a little bit. When you're scanning patients and you're starting off scanning, you may often see areas like this as a very common finding, and you think, oh my God, there's an avulsive tear there. Well, just realize again, this is all due to anisoptrophy. After a while, you begin to recognize the patterns of anisoptrophy. What you can do is you can move the shoulder around, or else you can basically just move the transducer, and by moving the transducer, you can get rid of that anisoptrophy and and make sure that there's no tear in those areas. So you need to, move the shoulder, move the transducer around, getting rid of those hypoechoric areas which are just artifactual and not representing real pathology. Now, what you do need to watch out for, which can be overlooked, number 4, are the presence of rim rent tears. Now, this is a sort of more easy to recognize. A avulsive tear, or deep sort of undersurface tear towards the proximal end of the supraspinatus tendon insertion. Now, but when you look more peripherally, what can be overlooked are small little avulsive tears, and here you can see this small avulsive tear. This is not an uncommon site of tear, and they're often associated with some bursitis. So do look out at the leading edge of the tendons, the anterior leading edge and the lateral leading edge of the tendon for these small little rim rent tears. This is what they look like on MRI, just small little avulsive partial thickness tears. They can be overlooked if you don't look at this area particularly and recognize what the appearances can be. Sometimes when you get avulsive type tears, that avulsive type tear may be filled with fluid,